Hello, guys. Good morning, everyone. Very good to meet you again. Welcome to our first pre-event that's been organized by our São Paulo staff, leading by Alan. And it's a very good pleasure to have you here. I'm Felipe. I'm a lecturer on neuropathology in Belo Horizonte, in the University of Minas Gerais. And today I'm hosting our first speaker. That's Dr. Omar Kujan from the University of Western Australia that started this day of activities. So I thank you very much for joining us for this event, you all, and especially Dr. Omar for taking a piece of his time to join today with us. So Dr. Omar, thank you very much. Welcome to our online platform, on our online meeting. It's a huge pleasure to have you here. So thank you very much. I think that's Dr. Omar. Just drop the connection. Just wait a little bit. Guys, if you want to send your comments, your message, questions, commentaries to share, please feel free, and I'll read some of them and ask some questions to Dr. Omar as soon as he returns online. We have a small problem.
Sorry, maybe something the internet
Hello.
connection. I don't know what's happening.
Can you hear me, Dr. Omar?
Hi.
Hello. Hello. Can you hear me?
Yeah, I can hear you very well. Maybe there was an interruption.
There's no
Yes, I
problem.
can hear you very well.
Perfect. Thank you very much again, Dr. Ma, for joining us. Thank you very much for this marvelous speaking, for this marvelous talk. It was amazing. Thank you very much. We have some questions. Well, we don't have lots of time for the amount of questions that we're receiving, but I would like to do one or two questions in this live section. One question from my side, I would like to ask you, in your experience, do you have any experience with these new artificial intelligence approaches in order to optimize our ability to predict what oral leukoplakia will transform or not? Well, do you think that these new algorithm, these artificial intelligence algorithms, will help us to predict malignant transformations in oral leukoplakia, or not so much? What's your view?
Yeah. Well, thank you very much for inviting me. To join the celebration of the 50th birthday of the Brazilian Society of Oral Pathology and Oral Medicine. Now, just only to answer that question, a lot of our, aspects in our life depend now on using AI. So definitely AI, artificial intelligence, can help with the prediction of malignant transformation. However, at the moment, there is no validated platform or algorithm can accurately predict the malignant transformation. There are so many attempts, including the use of clinical photographs or clinical information or microscopic features, or like a combination of these. But none of them have reached the threshold, which is 95%. So if you want to have a good tool, it has to achieve at least 95% accuracy. Otherwise, you have to deal with a lot of false positive, false negatives, and that is going to cause a lot of anxiety and also stress to the patients, and also you may miss some diagnosis. So I would say there's a future for the use of AI, but at the moment we don't have effective tool, and that's why we need to have more people working or further research in that area. However, it has to be what we could see a lot of attempts. However, they have poor design, poor study design, and that will lead to some invalid results. We want to see more robust multi-center studies and where people can work together and get some good outcome.
Well, fair enough. Thank you very much. Well, I have one question from Dr. Juliana Romani. She's asking a question from a clinical point of view. Well, she's asking, in your opinion, how should we behave with patients diagnosed with oral leukoplakia? How should we treat them? Do you, in your experience, do you recommend to remove the leukoplakias, to follow these patients? For how long should we follow them? So, what criteria you use to take these decisions? Could you please comment a little bit for us how to deal clinically with these oral leukoplakia patients?
Well, well, I mean, that's really quite tricky question. Thank you very much. It's really an excellent question, but also it's quite challenging because at the moment there is no validated protocol for the management of oral leukoplakia. There are several protocols which is being published by several centers over the world. I mean, in the world, based on their experience. It's either from Western Europe or from North America or from South America, and little from Asia. I mean, also we have protocol here in Australia. So the whole idea, which is I would start by saying you need to establish an accurate diagnosis of oral leukoplakia. And you need to have a good biopsy, which is from representative site of the lesion. And this is very important. Once you establish the diagnosis and you confirm the patient whether they have a dysplasia or not. So based on the histopathological diagnosis and also other clinical variables, including like age, social history, including tobacco use and alcohol drinking, based on that, you could stratify the patient into different categories. Now, if the patient, I mean, is female and has no risk factors but has leukoplakia, well, definitely this is in high risk group, and especially if the lesion has dysplastic changes at moderate level and above. And in that case, I would recommend, complete resection of the lesion. Now, in most cases, the resection or the removal won't be complete because some lesions they could have invisible margin, and you may need to use some adjunct tools to help you in delineating or identifying the accurate margins of the lesion. So that would enable you to have a complete resection of the lesion. And right now the evidence supports the use of narrowband imaging, where it is very effective in delineating the margins of the lesion. Now, in most cases, leukoplakia is managed by wait and see. The reason why, because some cases, they don't respond to treatment and they have recurrence. But what is effective, which is about mitigating the risk factors that we can manage. There are some non-modifiable risk factors like gender, like age. We can This something we can deal with. However, with social habits like tobacco smoking, or the use of smokeless tobacco, or drinking alcohol, we can talk to the patients, or vaping. All of these factors can be managed well, and we need to provide counseling to the patient to stop, because this is the starting point for prevention. Now, whether we can use some chemopreventive agents, this is an issue which is very debatable about the effectiveness. There are no, at the moment, there's no effective chemopreventive agent that can be used as therapeutic, agent. So we can administer that as topical or systemic administration. However, I would say, you need to have really an overall evaluation of the lesion and the patient. So you need to consider not only the lesion itself, but also the patient. And you need to look to the whole case, holistically, having really, you assess the big picture, and also you try to see what is the best. I'm sorry, I don't have uh, I would say a definitive answer,
Yeah.
but at the moment, depending on your assessment, you could have several management options. But at the moment, mostly we follow up the patients regularly. If they have dysplasia, I usually recall the patient every 3 to 4 months, and we don't repeat the biopsies unless we see some clinical changes.
Yeah.
Now, in my experience, I found the use of oral brush cytology is very effective. So rather than to take a surgical biopsy, incisional, or using bunch, or a scalpel biopsy, you could use a brush biopsy where you look about the changes in, but you need to have really a good representative sample. That is quite, effective, and there's evidence at the moment about the use of oral brush cytology. And what we're trying to do, we're trying to combine oral brush cytology with DNA ploidy testing. And that is going to be very, very powerful and effective in stratifying the risk of malignant transformation. So rather than to take a whole biopsy, or take a biopsy, it's quite easy, or I would say manageable, to take only a brush sample. And then, but it needs, I would say, training for pathologists to check about the morphological changes. And then also about they need some sort of another supporting test. So looking about the cytology itself is limited, but that's why we would recommend to look about some biomarkers. Now, border planning has been proposed as a good biomarker, so it can be used as well. We haven't used it in combination with oral brush cytology, but that's something can be done, and we're looking to see that, if to just want to check about the utility and the accuracy of that. I hope that have answered your question. Let
Yeah,
me
for
know
sure.
if you have any comments, or if you want to share your feedback.
Yeah, that's a very, very tricky question, as you said, because it depends on some variables, for sure. Well, we have a comment here from Dr. Marcelo Esperanjo, who is an expert on the study of leukoplakias, and he's just highlighting. He wants to highlight the importance of evaluating and identifying each of the architectural and cytological chains in order to be able to count them and at the end of the evaluation. And he also says that the binary system is particularly useful to separate high grade and low grade or epithelial dysplasia that was originally classified as moderate dysplasia. Well, the moderate dysplasia, I believe that might be a very a difficult part of this spectrum, and this binary system has definitely helped us to to overcome this group of lesions. Actually, we here in Brazil, we frequently use your recommended binary system, and it's very much famous and prestigious among us here in Brazil. If you want to comment a little bit about this binary system, would be nice.
Yeah, thank you very much, Marcelo, for your, for your question and for your comment. The binary grading system. When I tried to, when I had the idea to establish the binary grading system, we tried to simplify things rather than to have at that time we had five categories for grading or epithelial dysplasia. Now, WHO moved into three-tier, grading system: mild, moderate, and severe. So binary grading system is to help with moderate, because we know most of in all low grade, all mild cases will go to the low grade, all severe cases will go to the high grade. However, what we're going to do with moderate, that's a tricky point. Some people, they combine it with severe as high risk. that's not the case, because you're going to have a good proportion of cases where they have little changes and they need to be moved to the low grade. So that's why we try to use a threshold to help with with the binary grading system. And that's what we're planning to do now with the introduction of new features, whether this is going to change the way how we're going to work with the binary grading system. However, what I would like to say here now, irrespective whether you're going to use binary grading system or a three-tier grading system, the whole point, which is about identifying dysplastic changes in the first place. Once you have a lesion which is recognized or diagnosed as dysplastic, that will make the major change to the lesion and the patient, because it's not only increasing the risk of the malignant transformation of the lesion, but it also increases the risk of developing cancer in the patient itself. That's the whole point. We Because of the field change, it in most cases, carcinoma may develop in other sites, not exactly the same one where you found the dysplastic changes, because there's sample error. When you do, that's why I said at the beginning, if you want to have a good management, you need to correctly select the right site of your biopsy. And once you do that, because histopathologists, are binded to the tissues that they have received, and that is determined by the clinician. And that's why we would like to have really a good clinician who can select the right site for the biopsy. Then you have really a good evaluation of the lesion, and then you could stratify the risk based on that. So to me, the major point here, it's not about the grading itself, it's about the recognition of dysplasia. And from my, I would say, little experience, or let me put it in this way, there are a lot of cases where either overdiagnosed or underdiagnosed.
Mhm.
And general pathologists tend to have to underdiagnose. Some people, they tend to overdiagnose. We want to be accurate in our evaluation, and that's why we want to have a good assessment of any biopsy. And also that's why we recommend, I highly advocate for any biopsy with dysplasia to be examined by two independent histopathologists. In that case, you're going to have consensus between the two pathologists where they discuss the features and they agree on the diagnosis and the grade. And you're going to see a lot of good diagnoses have been achieved.
Okay, perfect. Dr. Ma, thank you very much. We have more questions, but unfortunately, we don't have more time. I would like to thank you very much again for your time, for your participation here.
Hi,
Uh,
Philip.
um, and then, can you hear me? Can you hear me? Okay. Hello? Well, I might have lost the connection again. I just concluded our talking. Thank you very much, Dr. Omar. Thank you very much for the audience. And then we are continuing with the event. And I hope to meet you all guys very soon
Yes.
again. Well, I think that we lost the connection. Thank you very much for everyone for the questions. And I hope you have a very nice pre-event. Thank you very much.